YouTube. I will click on go live.
Yes, you can start.
Sir, we're in go live, sir.
Yes, sir. Please start. Yeah.
That thrives on a robust research and development program. 21 years of expertise in pharmaceutical, 25 plus state-of-art manufacturing facilities, presence in more than 120 countries, 15,000 plus employees across globe, 200 plus products in portfolio. Hetero Research Foundation started as early as in the year 1995, spearheaded by more than 500 top-notch scientists, excellence in developing generics, difficult to make and complex APIs, novel drug delivery system, new chemical entities, and biosimilars. Hetero Healthcare is one of the world leaders in developing and manufacturing a wide range of brands in various therapy segments, including gastroenterology and hepatology. More than 3 decades of experience in manufacturing and marketing pharmaceuticals. Hetero Healthcare has also been in forefront providing drugs for COVID-19 pandemic, such as COI4 injection, that is remdesivir, and Favipiravir tablets, that is Favipiravir. Hetero Gastrocare is committed towards creating awareness about hepatitis B and C, along with products like Heptivite, providing access to high-quality medicines at affordable rates, and enriching lives of patients for better well-being. Adding to the portfolio, we are pleased to introduce MidoHep, a brand of midodrine hydrochloride, a vasoconstrictor being widely used in orthostatic hypotension and various secondary hypertensive disorders. It has been recently shown to have a significant improvement in cirrhotic patients with ascites. For further detailed discussion on this topic in our today's webinar, that is novel advances in the management of refractory ascites and HRS, I would like to introduce our moderator and speaker. I would like to introduce our moderator, Dr. Arun R.S. sir. Arun R.S. sir is a senior consultant in gastro at Madras Medical Mission, Chennai. Arun R.S. sir has completed his MBBS in Christian Medical College, Vellore, MD General Medicine at Government Medical College, Mysore, and DM Gastroenterology in Christian Medical College, Vellore. And additional qualifications, research ethics and good clinical practice, CMC Vellore, interventional EUS training, University of Alabama, USA, advanced interventional EUS observerships in AAG, Hyderabad, hands-on training in third space endoscopy, ESD, POEM, Mumbai, STRETTA, hands-on training AAG, Hyderabad, endoscopic suturing, hands-on BIDS, Mumbai, reputation and practice management, IIM, Ahmedabad. Sir is currently designated as senior consultant gastroenterologist in Institute of Gastroenterology and Liver Disease, Madras Medical Mission, Chennai. Sir has got some great academic achievements, that is SSLC state rank holder 9th, merit scholarship awardee for first and second year MBBS, first certificate of honor for pharmacology and forensic medicine, college topper for MD General Medicine, first prize for poster presentation in the category of nutrition at ISG Con 2010. Membership in professional bodies like ISG, INSL, SGEI, AAG, ACG, and EASL. And today we have our eminent guest speaker, Dr. N. Arun sir, Assistant Professor of Gastroenterology, Department of Digestive Health and Diseases, Chennai, visiting consultant at Bilroth Hospital, Chennai, and Director, Chandra Gastro Liver Clinic and Endoscopic Center, Chennai, area of interest, post-liver transplant immunosuppressive guidelines, plasma pheresis in ACLF, and life member for ISG, INSL, SGEI, and IAP. And I have a great pleasure in having two eminent faculties here on this webinar. I would like to request and hand over the session to our moderator, Dr. R.S. Arun sir. R.S. Arun sir, please sir.
Good evening to one and all. It is my pleasure to introduce Dr. Arun, who is a young, enterprising interventional gastroenterologist rising to prominence in Chennai. He is very lively, pleasant, and interactive, and very knowledgeable in various disciplines of gastroenterology. So it will be a wonderful session wherein he will enlighten us about the novel advances of management in refractory ascites and hepatorenal syndrome. So it is my, I also would like to acknowledge the effort Hetero team has put in to organize this webinar, and I welcome all participants for an hour of academic discussion on gastroenterology.
Yes.
Dr. Arun, please.
Thank you, Dr. Arun sir, for a very brief introduction. It's really a great pleasure for me to be along with you, sir. This is the first time I'm joining with you in this forum, in this during this pandemic and in this dawning hours of this Sunday. It's really a great pleasure for me to join along with you, sir. And one word, you are a very good senior to me, and through you, we came to know about many things, sir. So, as a consultant, a senior consultant in Tribunum Hospital, it's really a great pleasure for me to have you today in this session, sir. And moreover, I also would like to thank Etro Pharma to give you opportunity to share some knowledge about what's happening in refractory ascites and hepatorenal syndrome. And I welcome all the delegates who have been participating here, so senior consultants and friends, to discuss something about the novel advances in the management of refractory ascites and hepatorenal syndrome. So directly we are going to enter the discussion. So what's a brief, see why we have chosen this topic? That's the most important thing for me to discuss right now. So, because see, day in and day out in our routine practice, we have been getting frequently about a cirrhotic patient. If the patient is going to be cirrhotic, sometimes the patient will be compensated, sometimes the patient will be decompensated. Once the patient is going for decompensatory phase, once the patient is going for end-stage liver disease, what's the problem is going to set in the patient and may develop ascites. But many of the practitioners, even the general physicians, some surgeons, or even the leading gastroenterologists, so many other consultants are being managing this kind of scenario frequently. But when we are going to do this management, how is it possible? How is it possible? I mean, in what way you're going to monitor? How are you going to titrate the dose? What is the initial regimen you're going to start? Or what are the various complications you are going to anticipate in the case of ascites? Once the patients develop multiple other complications, how are you going to manage? These are all the various areas that I'm going to brush your knowledge right now in this area of discussion. See, to discuss about cirrhosis, as we all know that it's nothing but the complete distortion of the liver, the hepatic architecture is going to go down, and apart from that, and there will be a formation of regenerative nodules, which will be, most of the time, will be irreversible. So in early stages nowadays, but even then, some evidence of cirrhosis, even because of alcohol and other things, there is some evidence show that the cirrhosis is still reversible at some point of time, but most of the time it will be irreversible at the time of presentation. So once the patient is going for cirrhosis, as we all know that the various etiology in India, if you're going to look, alcoholic liver disease is one most common entity. Frequently we'll be doing, even males and females, we have been getting many of alcoholic liver disease case reports have been there. Apart from that, viral hepatitis, as we all know that the chronicity because of B as well as C and non-alcoholic fatty liver disease is more common in the West. Nowadays is even rising up in the Indian population, other scenarios. These are all the major area for, apart from that, there are multiple other etiological factors for cirrhosis. That's not in the area of discussion right now. So, how the natural history of cirrhosis which you're going to be lead, because based upon the various etiology and various factors, and if you're going to take a normal liver, followed by, say, just for an example, I'm giving you a scenario. If the patient has HCV or other infection, the patient can go for chronicity. Once a patient can go for chronicity, or 20 to 30% of the patients can go for cirrhosis. Once a patient is going to cirrhosis, there is around 1 to 5% of the population can go for hepatocellular carcinoma, one of the most dreadful complications that may be anticipated at around 20 to 30 years after the initial presentation. So this is the various complications. So if you're going to look, that's the basic definition about compensated and decompensated. The patient doesn't develop ascites, the patient doesn't develop any evidence of hepatic NCAF, the patient doesn't develop any evidence of coagulopathy or other major complications. But once a patient is going for decompensation, as we all know, right from the basic knowledge that ascites very bleed, and sometimes the patient will have worsening of bilirubin, as well as the patient can develop a hepatic coma, nothing but hepatic NCAF. So this is how the progression of cirrhosis is going to set in. See, if the stage 1, 2, and 3, and 4, as per the ESL statement, what they mentioned that if the patient in stage 1 is compensated with no evidence of esophageal varices, which that shows evidence of mortality around 1%, but as the patient, if the patient is going to develop evidence of varices, it shows evidence of mortality around 3.4%. Once the patient gets decompensated, it means the patient falls into category C, stage 3 and 4. The patient can develop ascites, the patient can develop the massive GI bleed, in which the scenario, the mortality rate will be going almost around more than 50%. So the major complications as well right now, right from the basics, any bleed, hepatoportal, hepatorenal, or spontaneous major infections can set in, or the cardiovascular disturbances, or the patients have neurological issues. Sometimes the hepatocellular malignancy can supervene. Also the thrombotic, because always you should remember the cirrhotic is a procoagulant state. There is evidence of thrombosis can be predisposed in various other pathologies. So To discuss about this scenario of refractory ascites, before switching over that, so we will take a brief case snippet, and so this is how frequently we are approaching. So in your routine practice, if you're going to get a male of around 50 years who's going to present you with history of NASH-related cirrhosis, with history of decompensation in the form of ascites, and is male. So male is nothing but bilirubin or creatinine. If you're going to take into account its male sodium, if it is going to be more than 22, and in many centers, they'll be doing paracentesis. So some centers, they'll be doing frequent large volume paracentesis. So if the patient is going to present with you evidence of large volume paracentesis, which is nothing but removal of around approximately 5 liters of fluid at one point of sitting, if you're going to do large volume paracentesis, so what is going to happen if you're going to put the patient on diuretics? Sometimes what will happen, the patient will have worsening of creatinine. The normal creatinine will be worsening because of we are not very sure whether it's because of diuretic-related complication or anything else which is being supervened in this presentation. So for example, the creatinine value will be going around 1.5 to 1.8, but the BP is still in the lowest end of 90/60 with evidence of pedal edema. In this scenario, with evidence of large volume paracentesis, with worsening of creatinine, if the patient is on diuretic, how are you going to approach this kind of patient? How are you going to proceed with this kind of patients? So to discuss about that, always you should remember that a transition from compensated to decompensated cirrhosis in any population because of any other etiology can progress at the rate of around 5 to 7% per year. But if you're going to see that the initial, what I've been discussing, if you want to analyze all this pathology, you need to see the liver stiffness measurement by fibroscan and other things which is being available right now in many centers. Also, we need to measure the HVPG gradient. So always if the HVPG gradient, it should be more than 5, I mean, if it is going to be more than 5 and if it is going to be less than 10, it should be around stage 0. And if the HVPG, if it is going to be more than 10, and liver stiffness, if it is going to be more than 20, it is stage 1, and stage 2 is almost equivalent to that. But once the patient is going for decompensated, that's what have been discussed, stage 3, 4, and 5, the patient is going for a further late decompensation phase, that's nothing but stage 6, in which the patient is going for refractory ascites, persistent portal system NCAF, and sometimes the patient will have worsening of jaundice, infections will supervene, and multi-organ dysfunction, and finally this will predispose to ACL, acute chronic liver failure can occur, and which leads to the death. So always we need to take care, once a patient, we need to prevent the progression of this kind of scenario to set in. So this is about the brief analysis, what's happening about the median survival in this kind of patient, that multi-stage model for the clinical course of cirrhosis. And if you're going to look into the compensated and decompensated, if the patient is asymptomatic, the survival is approximately 12 years. Once the patient is going for decompensated phase, the survival is going to come around 1 to 2 years. So that's what I've been discussing with you. So if you're going to assess about the pathophysiology of portal hypertension, is a very interesting area because portal hypertension ascites is the most important thing to be discussed in this management. So what is going to happen in liver cirrhosis? Once the liver architecture is going to completely distorted, so there will be evidence of fibrosis, which will predispose to portal hypertension, intrahepatic pressure, and everything is going to climb up. So there will be shear stress will be there, and the vasodilatory pathway is going to get triggered out. Once a vasodilatory pathway, if it is going to get triggered, what's happened? There will be nitric oxide release. That's the most important thing, vasodilatory activation, which is being frequently encountered nowadays. So nitric oxide release, and which will predispose to mesenteric angiogenesis, and which will predispose to hyporesponsiveness to various vasoconstriction therapy. If you're going to think about various vasoconstrictor, there will not be any response to that various vasoconstrictor therapy, which will predispose to splanchnic vasodilatation, and this will increase the splanchnic capillary filling pressure, and this will predispose to arterial underfilling and will cause evidence of ascites. Though there will be evidence of sodium retention and other things which will predispose to ascitic formation. See, the major thing what we are going to do is increase, the systemic vasodilation, the splanchnic vasodilatation process, along with renal vasoconstriction if the patient is going for end-stage liver disease, along with if the patient is going to develop HRS and other complications. So these kind of presentation will be leading you to multiple vasoconstrictor pathways and will be releasing anti-natriuretic peptide and all of the things which will predispose to multi other complications that slides. This is briefly about the pathophysiology of portal hypertension, how the ascites is the arterial overfilling. As you all know that the increased osmotic pressure and low osmotic and increased hydrostatic pressure, which will predispose to ascitic formation, is the most important thing to be conveyed right now. So If you're going to look into the slide, if the patient is having any minimal evidence of ascites in this background, if the patient is going to present with mild elevation of renal function, and doesn't mean that the patient is going for HRS. Always you should remember that HRS is a final diagnosis which will predispose mostly at the end stage liver disease. Always don't think that once the minimal elevation of creatinine is there, don't label the patient immediately as HRS. That's one important thing I want to convey to you. And see, initial phase will be portal hypertensive in the background of ascites. Once the patient is being initiated with diuretic therapy because of splanchnic vasodilation, the patients and finally the patient can go for renal vasoconstriction. That will predispose to hepatorenal syndrome as the day goes on. So this is about the same slide what I will discussed. So this is about the natural history of ascites. The HVPG, if it is going to be less than 10, and if it is going to be more than 10 with moderate vasodilatation, severe vasodilatation, if the HVPG, if it is going to be more than 10, and extreme vasodilatation, that will predispose to. So portal hypertension to no ascites, uncomplicated ascites, finally to refractory, and once again, late stages, the patient can go for hepatorenal syndrome, which is nothing but the phenotypic renal dysfunction in the background of cirrhosis. So in this scenario, so the most important area for me to discuss today is how are you going to approach a patient with ascites and how are you going to tackle a patient with refractory ascites. So before switching on my area to refractory ascites, a brief analysis, brief statement about how do you target your ascites, how to control your ascites. Because when you're going to present with any fluid in the blood, doesn't mean it's only because of liver, it could be because of multiple other etiologies. We are well known, always we need to look for the cause, we need to look for the SAD. Means serum acetic albumin gradient. If the serum acetic albumin gradient, if it is going to be more than 1.1, that shows the evidence of portal hypertension in more than 95% of the patients. And we need to see if the serum acetic ISAC acid is or whether it's low SAC because of multiple other etiology tuberculosis are there, multiple other things we need to consider. And ISAC acid is nothing but we can, based upon the etiology, it could be viral, it could be because of alcoholic. Always in this scenario, we need to eliminate the predominant focus. First, what is the trigger? We need to identify the triggering factor. What is the thing which is going to precipitate this event? And next to that, first thing we need to identify, make sure that the patient is going to be adequate salt restriction. To discuss about that, I will join with, I will be taking all those things in my upcoming slides. And salt restriction and diuretics has to be enhanced. And we need to look for the precipitating factors like GI bleed, or if the patient is having any nitrogenous and non-nitrogenous precipitating factors, or if the patient is having evidence of HCC, or if the patient is having any drug abuse, like evidence of any usage of any ACE inhibitors or usage of any NSAID, so many other things. Always the first step in the management of ascites is you need to make sure that the patient should be on adequate salt restriction. That's the most important thing we need to take care. Once the patient is on adequate salt restriction, that itself will be taken care of. If the patient is having adequate salt restriction, there will be significant weight loss of at least around 0.5 kg, 0.5 grams per day. That's the most important thing. If you're going to have adequate, 0.5 kg per day, if the sodium intake, if it is going to be around 5.2 grams of salt per day. Initially, it was given around which is almost equivalent to 2000 milligrams. So low salt diet alone will be eliminating your ascites in around 10% of the population. So the first thing, eliminate your salt, the low salt diet. So how to recognize your salt restriction is being done in a proper manner that I'll be discussing. And once a patient, always you need to choose a diuretic therapy. Always when you're going to, you need to choose a potassium sparing diuretic. The first one, the aldosterone antagonist, that spironolactone can be taken. And if you're going to take spironolactone, always you need to combine with a loop diuretic like furosemide or torsemide, what we are going to use. And when you're going to use a diuretic, the ideally the combination of two diuretic, either you need to start from 40 milligrams of furosemide along with 100 milligrams of spironolactone can be started off in the management of ascites. So because why do we combine the diuretic? Because it will be acting on two different sides. Loop diuretic will be acting on the sodium potassium pathway, and potassium sparing diuretic will be acting on the distributing tubule, and all these things will be, so the contracting effect of hyperkalemia and other complications definitely will going to be controlled if you're going to use two diuretics simultaneously. Some adverse effects are being reported as well known gynecomastia and other things. And if this nothing works out, if the patient is developing other complications, we can add other diuretics like amiloride. But so the baseline diuretic dose will be 40 of furosemide, and it will be up to spironolactone around 100 milligrams. If this nothing works out, we can step up the diuretic slowly, and we can go up to 160 milligrams of furosemide, and we can also go up to 400 milligrams of spironolactone. But how frequently we are going up to this dose, that's a questionable issue to be discussed. See, once a patient, this is a very important thing to be discussed right now. So you are going to start the patient on diuretic. That's most of the persons, most of the doctors, most of the consultants will be doing that. But once the patient is going to be on sodium, diuretic support, how are you going to assess whether there's diuretic response? You need to take out the urinary sodium potassium ratio. It has to be more than 1. So how to see that? So always you should remember that if the patient is going to be an adequate salt restriction, which means around 88 millimoles per day of adequate salt restriction, there will be loss of around 78 and non-urinary losses of around approximately 10 millimoles. So if the patient is having adequate urinary sodium excretion, we need to target around more than 78 millimoles per day. So if the patient on adequate salt restriction alone without any diuretics, which means the urinary sodium excretion will be less. And suppose if you're going to add the patient with diuretic support with adequate salt restriction, so what are going to happen? So once the patient is being diuretic responsive, the patient will reduction of weight as beyond 0.5 grams per day. So the definite significant weight loss will be there, along with evidence of urinary sodium excretion will be more than 78 millimoles. Suppose if the patient urinary sodium excretion if it is not going to be more than 78 millimoles, and if the patient is having evidence of volume over, which means the diuretic resistant phase, the diuretic is not responding to the patient. And these are all the scenarios you should analyze before switching over the diuretic therapy. And we need to target a urinary sodium potassium excretion should be more than more than 1. That has to be targeted if you're going to manage the diuretic. So sometimes if there is no response, we can step up the dose of diuretic after 3 days based upon the clinical analysis spectrum. So our main area for discussion is nothing but refractory ascites. If you want to say refractory ascites, so even after large volume of paracentesis, even after maximum dose of diuretics, if it is not going to be respond, or if there is a residue in ascites, if it is going to recur again and again, or the early recurrence, so this is nothing but refractory ascites. If you are going to categorize the refractory ascites, there are multiple definitions for that. But one thing, the major classification is nothing but diuretic resistant and diuretic intractable. So what do you mean by diuretic resistant? You are going to give a maximum dose and it doesn't going to respond, nothing but diuretic resistant. What is a diuretic intractable? Even after giving a maximum dose of diuresis, sometimes even if the minimal dose of diuresis, you'll be getting other complications because of diuretics. You may getting electrolyte disturbances, you may getting other complications because of the diuretic intractable complications. So you need to stop diuretic because of that. So we cannot able to mobilize ascites. So that's nothing but diuretic intractable. So this is a basic definition about this refractory ascites. As we all know that at least 1 week of diuretic therapy on adequate salt restriction around 90 millimoles per day. That is the most important thing to be taken care of. And next to that, and when you say there is no response, means mean weight loss of at least 0.8 kg over 4 days and the urinary sodium output less than sodium intake. That's what we discussed with you. And early ascites recurrence means recurrence of grade 2 or 3, which means the patient is having within 4 weeks of initial mobilization. If you are going to do a paracentesis and within 4 weeks, again, the patient is having recurrence of grade 2 and 3 ascites, which means there is early ascitic recurrence. So as we all know, the diuretic can predispose to multiple complications. It can predispose to renal impairment, hepatic NCAF, hyponatremia, hypokalemia, and incapacitating muscle cramps can occur. So always you should remember that renal impairment is increased creatinine by more than 100% to value of more than 2 milligrams per deciliter, and hyponatremia of the serum sodium is going to less than 125 millimoles, and hypokalemia based upon the clinical presentation. This is the same thing what I will discuss. So we need to target the urinary sodium potassium excretion of more than 1, along with urinary sodium loss should be more than 78 millimoles if the patient is going to be diuretic sensitive. And how do you going to manage the patient with refractory ascites? So once a patient being diagnosed with refractory ascites, it could be because of multiple modalities of treatment can be tried. It could be medical therapy. It could be because of large volume paracentesis. You can go for tips, nothing but transjugular intrahepatic portosystemic shunt. And finally, we can go for liver transplant and other new modalities and palliative support is being available right now in the market to tackle these ascites. And what is the initial treatment for this refractory ascites? We need to eliminate the harmful source. So we need to eliminate the precipitating factor. Suppose if the patient is on any EAC inhibitors or the drugs or NSAIDs, we need to stop that. And always, if you're going to manage a patient with ascites, you need to target the MAP, that is the mean arterial pressure. If you are going to target, always you should remember that some patient with cirrhosis, in the patient of decompensated phase, the usual MAP will be around 50 to 55, and you need to target the MAP that should be at least around 10 millimeter of mercury from the baseline. So we need to target at least around 60 to 65 for this kind of patients to improve the clinical scenario. Once a map, everything is going to attain in a proper manner, which means if the map, if it is going to be more than 82 in this scenario, what there means around 70% chance of survival for more than 2 years, and those with the map of around less than 82, there are multiple studies I mentioned, the 20%, the chances of survival will be coming down to approximately 20% of the period of survival. So AC inhibitors and ARBs, what's going to happen in this country if you're going to use along with this thing, which means it will decrease the MAP and also block the production of compensatory vasoconstrictors. So always, when you're going to manage a patient with ascites, target the MAP and improve the MAP more than 10 millimeter of mercury over the baseline. Those things, basic things, has to be taken care when you're going to manage a patient with refractory ascites and other complications. So next to that, always any patients to ensure that the low salt diet, as I discussed with you, 2000 milligrams per day, and no added salt. And diuretic should be discontinued permanently in patients. Suppose if the patient is going to develop a diuretic in these complications like hepatic NK for renal impairment, and it can continue only when the urine sodium, if it is greater than 30 millimoles per day. And this is another interesting area to discuss about, that the role of beta blockers in selected patients with refractory ascites. So there are multiple issues, multiple discussion, even within this statement and from BJ Chandigarh, they are given multiple papers for that, and IB has also done multiple studies for that. So what they may mention in that, so we can always titrate the dose at the lower dose, because once you're going to stop the beta blocker completely, suppose if the patient is having hypertension, so in this we have taken a clinical scenario of around 90/60 BP. So if the patient is having hypertension, doesn't mean you need to stop the beta blockers completely. So you can go for the lower dose of beta blockers, like propranolol. If you're going to take, for example, you can give around 20 milligrams. So rather than, because carvedilol most of the time will be having additional vasodilatory, because alpha, it also having a alpha property. So carvedilol sometimes will not be used in this kind of scenario, and you can go for a lower dose of propranolol, because only when you're going to give a lower dose of propranolol, you're going to take care of UGA bleed. The prophylaxis for upper GA bleed will be strongly ensured. And next to that, if you're going to give a lower dose of propranolol, the prevention of subacute bacterial, spontaneous bacterial peritonitis will be more. And these things, to prevent all this infection, other complications, always you should not stop the beta blockers completely, as per the various school of concepts what's being going on right now. So we can give a lower dose of propranolol, and as per the Bavino 6 statement, what they've been given, the doses of the beta blockers can be completely, can be easily reduced if the patient is having BP, if it is going to be less than 90. And if the serum creatinine, if it is going to be more than 1.5, and if the patient is having hyponatremia, if it is going to be less than 130, so the non-selective beta blockers in this entirety can be reduced. And now the most important area for us for the topic of the day is nothing but oral midodrine. So if you're going to think about this oral midodrine, it's nothing but it's a oral vasopressor. It's an alpha agonist. It's a very simple mechanism of action. So what is going to happen? It will going to increase the blood pressure, and it is going to improve your MAP, and when the base, always the initial presentation we are going to use for orthostatic hypertension, and also in case of cirrhosis, the role of even in case of diuretic resistant ascites, there is significant evidence to show that there is a potential role for this midodrine to take over. So basic pharmacology about this midodrine, as we all know that it's off-life, it's a metabolite. The metabolic process is desglyamidodrine, and the off-life will be around 3 to 4 hours approximately, and it metabolized by the liver into active metabolism. That's what been discussed, and predominantly it's cleared by active renal secretion. So this midodrine will be converted to desglyamidodrine, and once the prodrug is being formed, it's being strong potent alpha agonist. So alpha agonist will, what's going to happen? The patient will be having the basic pathophysiology of splanchnic vasodilation will be taken over. So there will be splanchnic vasoconstriction, which will increase the vascular tension and elevation of blood pressure, and will improve the systemic circulation. And once the systemic circulation is going to improve, there will be improvement of your renal function and increased sodium and water excretion, which will reduce your ascites in this kind of presentation. So we should know to whom we are subject in, what are the conditions when the patient is being subjected to midodrine, how are you going to assess the dose, what is the titration guidelines, these things has to be targeted if you're going to subject the patient with midodrine. And So there are multiple school of thoughts for discussion and multiple studies, multiple papers are being there for various dosage regimen for midodrine. And right now, most of the time I'll be giving up initially around 5 milligrams TDS, and sometimes we can go up to 7 milligram. And there are some papers even 7.5, and there are some papers even up to 17.5 milligrams twice daily have been tried, and some papers even up to 12.5 milligrams twice daily been tried. There are multiple papers to quote for that, but so always we need to assess a map. We need to target the baseline map should be more than 10 millimeter over the baseline levels once you're going to start the patient with midodrine, and that's the main thing. And 2.5 milligram of incremental of dose we can try along with that. So we can take at around 3 to 4 hourly interval, predominantly in the morning or in the midday, or at least 4 hours before bedtime, to prevent evidence of supine hypertension and other complications to set in. This is very interesting paper from PGI, Professor Virendra Group. And what have been done in that, if you're going to take a standard medical treatment along with that, if you're going in 40 cirrhotic patients, if you're going to take midodrine, so the standard medical therapy with midodrine, what they've been given that if the patient is going to be on midodrine support for around 7.5 milligram, they have taken a 7.5 milligram twice daily. So what is that standard medical therapy, which means a sodium restriction, adequate salt restriction, along with you're going to subject the patient with diuretics, along with repeated large volume paracentesis with evidence of albumin support. So albumin 1 gram per kg of albumin support, which we are going to analyze the outcome, control of ascites. So what they've been given, rather than going only for the standard medical therapy, if you are going to add midodrine to this group, there is significant potential benefit in improving the map in this kind of population. So oral midodrine, this is another paper which has been taken from AASLD position statement. Oral midodrine, what have been given to shown improved clinical outcomes and survival in patients with refractory ascites. Its use being considered reasonably. So it is going to improve the urine volume, urine sodium, and mean artery pressure, and time survival, other things. This is another paper from PGA, what have been taken. So in non-acidemia, so in non-acidemic patients with cirrhosis, with or without ascites, they have been analysis study. If you're going to use a short-term use of midodrine, what's it will be comparing with a renal hemodynamic as well as a systemic hemodynamic. So renal hemodynamics are like urine excretion of sodium and other things. Apart from the systemic hemodynamics like mean artery pressure, everything is going to be significantly elevated in this paper. If you're going to use in non-acidemic patients for a period of around 7 days, if you're going to use midodrine. So this is about the hormonal measurements. This is another paper from Journal of Hepatology, and what I mean to measure the hormonal assessment. Suppose in this study, what have been taken after first 3 hour midodrine administration, they have proven that there is a significant elevation of MAP and systemic vascular resistance, and a significant, these things are being analyzed over the 3 hour period. And so there will be significant MAP elevation in SVR has been proven once the patient is going to be used with midodrine and other things. So what they've been analyzed about the hormonal levels, if you're going to administer midodrine for a longer duration, that shows evidence of marked decrease in plasma renin activity. So if you're going to, why we are taking this plasma renin activity? Because the PRA is one most important thing to analyze if the patient is going for PICD, nothing but paracentesis induced circulatory dysfunction. So if the patient is going for repeated large volume paracentesis, the patient can go for PICD and other complication. Once this kind of complication sets in, the PRA levels will be going more than 4 nanograms. Those things I'll be checking over in the upcoming slides. But if you're going to use this midodrine, there is evidence that the marked decrease in PRA and nitric oxide is potential vasodilators, and also in the plasma level of ADH. But that doesn't mean that there is no significant change in the level of 18-natriuretic peptide AMP or in the level of plasma aldosterone levels if you're going to use midodrine for a shorter duration of period. This is another paper, what have been taken into account if you're going to combine this midodrine versus octreotide. So what they mentioned in that both midodrine and octreotide can reduce the plasma renin activity, but midodrine can reduce PRA and increase significantly GFR more potently than octreotide if you are going to use. So it shows the evidence of midodrine is having a significant beneficial role in the management of refractory ascites. This is by Professor Virendra Singh and group, and what they've been done. So because most of the studies from PGH training for management of refractory ascites have been apart from ILBS, and so what they've been done, they have been taken midodrine around 7.5 milligrams and clonidine around 0.1 milligrams. So being given a titration. So and around 60 patients they've been taken with evidence of refractory ascites. In this, what they've been proven that midodrine and combination of midodrine plus clonidine plus standard medical therapy will always proven that the superior to standard medical therapy alone, but no superiority of combination over midodrine alone has been documented. This is another thing about tolvaptan, briefly about, if you're thinking about tolvaptan, you can go around 7.5. What is this tolvaptan? It's nothing but the vasopressin antagonist. So what's going to happen if you're going to give, it will be predominantly the vactans is going to locate predominantly the vasopressin, will be predominantly located in the V2 receptors and will be acting on the aquaporin channels, which will improve the sodium excretion and which will improve the sodium elimination, other things. So, so once you're subjecting the patient with water excretion, other process to stay in. So if you're going to subject the patient with tolvaptan, always there is some evidence of black box warning when you're going to use tolvaptan and other things. But in this paper from 2017 journal, what we mentioned that midodrine and tolvaptan, if you're going to use, there is significant benefit at around 1 month and 3 month period, rather than combine, rather than giving either midodrine or tolvaptan alone in improving the mean arterial pressure and other things. So that's what the V2 receptor antagonist is. Predominantly, the vactans will be acting in the distal tubule and to increase the solute-free water excretion. And there are multiple studies being proven that there is some evidence to think in terms if you're going to combine midodrine and tolvaptan. So this is another paper. What they mean is first month, second month, third month, and sixth month, they have been looking into the role of midodrine. In this, they will be categorizing the patient with complete response or partial response or no, absence of response or no response. So what do you mean by this complete response, which means the complete elimination of ascites, and partial response, which means the presence of ascites not requiring paracentesis. But absence of response means the presence of ascites, which will make you to, in which the patient requires frequent paracentesis. So they have been taken into the account. So what have been see at month 1 and month 3 and month 6, they have been did the study, and they have shown a reasonable good response if you are going to use midodrine in this. So about midodrine, it's nothing. So what is the major mechanism of action? Is nothing but it will predominantly improve MAP. That's the most important thing to be targeted. About 10 millimeter of mercury over the baseline lower, and next to that, the cardiac output is going to come down, and systemic vascular resistance is going to increase, and urinary output and urinary sodium excretion will be increased, which will reduce the ascites, and plasma renin activity is going to come down, which will improve the complications of PICD, and no renal or hepatic dysfunction being reported in various studies being shown over. And this is another paper being taken over, but nothing much to discuss in this slide. Along, if you're going to think about midodrine, if you're going to combine with the rifaximin, always in the background of rifaximin, you're going to give to prevention of hepatic handicap and other complications. Most of the time in the back decompensated cirrhosis you're going to use. And if you're going to use rifaximin and midodrine, that shows some clinical outcome. There should be some improvement in renal hemodynamics, and short-term survival has been reported. But these studies are still need to be more validated apart from that in the management of refractory ascites. So the most important thing is midodrine plus albumin for prevention of ascites in the background of cirrhosis who are awaiting liver transplant. It's a very interesting paper from Journal of Hepatology in December 2018 been taken over. So what's the main thing they've been taken over, that if you're going to use midodrine and albumin in patients who are undergoing large volume paracentesis, what they've been given, mentioning that you need to use a longer duration of midodrine rather than you going for a shorter duration. So if you're going to use for a longer duration, there is definitely improvement of hyponatremia, there is definitely improvement of renal impairment. All these things, in the renal perfusion, other things will be improved if you're going to use midodrine with versus albumin. And albumin also has by answer trial that we'll be discussing in the upcoming slide for continuous frequent long dose of long-term albumin support also to be done in the management of refractory ascites. So brushing out about what's the main thing about, the key main pathology for refractory ascites is mainly because of solid water, sodium retention and water retention. Apart from that, the compensatory mechanism is not going to work out. And once the compensatory mechanism fails, the vasoconstrictor and other pathways is going to supervene. So all these things to be taken over either by midodrine or other combinations along with dietary restriction. This is a major area to be discussed. And midodrine plus albumin will always have a significant reduction in renin as well as in aldosterone levels. But so however, midodrine plus albumin did not prevent the major complications or did not improve the overall survival when you're going to compare with multiple papers or other trials to go on. So Final outcome is midodrine is non-inferior to albumin infusion in terms of maintaining renal function, serum sodium, and 24-hour urinary sodium excretion, and no difference in mortality between the groups. And long-term intake of midodrine is more useful rather than short duration of support. So apart from the role of midodrine and other medical line of therapy, there are other modalities like large volume paracentesis and tips and liver transplant. That's what been discussed. As we all know that large volume paracentesis, what's going to happen if you're going to remove frequently 5 liters? It's not more cumbersome, it's very difficult. That's why we are going to add midodrine, albumin support. We need to target the MAP and other things. So if you're going to do all these things in a proper manner, the BP and other things will be targeted. And apart from that, the clinical picture definitely is going to improve. And the large volume paracentesis definitely will going to come down rather than doing once in 2 weeks. Definitely, I have seen so many patients in our study. We've been experiencing many patients. If you're going to do along with midodrine and albumin support, if you're going to give for a longer duration, that shows significant reduction of large volume paracentesis in these kind of patients along. So large volume rather than giving frequent, going for frequent LVP. So if you're going for frequent LVP, the most important target, we need to target the spot urine sodium potassium excretion. It should be more than 1, which means it indicates a strong pointer to determine that the 24-hour urine sodium excretion is more than 78 millimoles, and there is a good response, weight loss and other things. So albumin is given predominantly, that's what mean. See, for every 5 liters, so 8 grams per liter. So for every 5 liters of large volume paracentesis, we need to give albumin support. So around 8 grams per liter of to be given if you're going to use albumin. And there are various proportions, we have a 5%, 20% that we frequently use 20% albumin support. And albumin either infused during or shortly after the paracentesis. That's the most important thing if you're going to look at this trial. And sometimes we can combine terlipressin intravenously, that 1 milligram at onset of paracentesis and 1 milligram at 8 hours. This is another paper being quoted, and 1 milligram at 16 hours. And if you're going to give midodrine, terlipressin and midodrine in the management of refractory ascites may be as effective as albumin, because if you're going to see the cost of albumin is very high, and apart from the terlipressin is next to that, and albumin and midodrine is slightly less to that. So if you're going to combine terli and midodrine, it's almost equally effective in the management of refractory ascites rather than using albumin alone. So serial paracentesis will cause sarcopenia, depletion of proteins, malnutrition, and predisposed to multiple infections, SBP and other things can supervene. So we need to give albumin in this kind of patients to prevent other complications. This is what about the ANSWER trial, very interesting thing. And one more trial is that I didn't put it in my paper, that's MAC trial. In this, all these things what been discussed about the long-term effect of human albumin support. See what they've been done in this study, a 40 gram twice weekly for 2 weeks, and then 40 grams weekly for up to 18 months. So twice weekly, they are giving around 40 grams of albumin support. So what they've been significantly assessed in this study, the overall 18 months survival was definitely going to be high rather than the standard medical therapy group if you're going to use this long-term albumin support to prevent frequent paracentesis and other complications, and also PICD to setting. So briefly about this PICD is nothing but paracentesis induced circulatory dysfunction can develop in around 18 to 30% of the patients who are going to do a large volume paracentesis. So what is going to happen mainly is because of multiple neurohormonal changes, as we are well known, because of hypovolemia and increased aldosterone activity, ADH activity, and the MAP level, which is going to be reduced, and systemic vascular resistance, which is going to supervene, which will finally predispose to renal perfusion impairment, and renal failure is going to set in. So PICD is one of the most important complications and more dreadful complication to be recognized earlier. Usually it will occur at around 6 days after the paracentesis. It sometimes remains clinically silent and may not be fully reversible most of the time. So if the patient is having PICD, so there are multiple. So always remember terlipressin, albumin, midodrine is having a different role. So what's the role of terlipressin versus albumin in paracentesis induced circulatory dysfunction? They have proven that it definitely is going to improve the renal impairment, and terlipressin also may be as effective as intravenous albumin in this paper to be quoted off. So, and in this study, if you have been taken over, they have been using check for other various colloids like albumin, dextran, polygylin, everything has been taken into account. So for volume expansion, other things. But what they've been finally concluded that albumin alone, which will prevent in this kind of patients, if you're going to use albumin support, and the chances of developing PICD will be only around 10 to 15%, rather than when you're going to use dextran and other things, from around 40 to 50% of the patients can go for PICD, and polygylin around 40% of the patients can go for PICD. These complications can be there. So the predominant thing always to be considered is albumin support if you're going to manage a PICD. So briefly about the other line of management, like tips. What's the main thing for tips if you're going to consider? And we have been frequently experiencing nowadays early tips, because I have seen some patient who presented to us with the evidence of early decomposition phase, even with moderate to moderate ascites. We are being subjecting the patient for early tips. Always you should remember certain things. What is the tip? Means nothing but transjugular intrahepatic portal systemic shunt. So you're going to shunt the pathway between the hepatic and the portal. Two major venous system as going to be taken into account, hepatic and portal vein. So there are some complications around hepatic NCAF, minimal hepatic NCAF. Some complications around 10 to 20%, around 25% of the population can be reported even with the strips, and other complications can be there. But if you're going to subject the patient early, if you're going to reduce the stent diameter, so if you're going to see there are multiple stent diameters, 6 millimeter, 8 millimeter, 10 millimeter stent diameter there. And if there are new papers, there are many papers to quote that if you're going to reduce the stent diameter to approximately 6 millimeter, that shows clear evidence, 6 to 8 millimeter, that shows clear evidence there is a definite improvement of this, improvement of hepatic NCAF, and the reduction of hepatic NCAF definitely will be there if you're going to use a reduction, smaller size stent. And early tips, rather than going for large volume paracentesis, frequent albumin, and other support, early tips definitely is having a strong potential role. But always you should consider tips is only a bridge to liver transplant. But MELD, so MELD scoring was originally developed to predict survival after tips insertion. So there are some complications being there because of tips, but early tips placement is one of the most important things sometimes to be considered before the patient subjected to liver transplantation. This is about the brief introduction about the stent placement between the hepatic and the portal venous system. There are one more new entity, nothing but alpha pump. It's being used for a longer time, but whether it's available in India, it's not much, and very few centers been tried. But the successful rate, the cost issue is still a questionable thing. So what is alpha pump? It's nothing but a peritoneal vesicle shunt, which means to the peritoneum you're going to divert the fluid into your urinary bladder and it will be excreted in the urine. But it is more cumbersome to use this procedure because you need a battery. The battery off-life will be very less, and you need to be frequent monitoring and some other complications. Sometimes the patient will develop a predominant source of infections, other thing. That's why, and more of the cost is slightly very high, and very few centers being tried, but not much of papers being reported. And so in this paper, what have been quoted that by Velo et al., around 40 patients and 9 centers for a period. But what they've been mentioned in this, few patients died because of sepsis and few patients because of worsening of liver failure or renal failure, undetermined causes being established. So the usage of alpha pump in our scenario to divert the fluid from the peritoneum into the urinary bladder. So still more papers to be validated. And these are all other modalities like peritoneal dialysis and fluorex and channel catheter. Nothing much to discuss in this area, but these are all other modalities of treatment being available in the management of refractory ascites. That's the main interest for me to show these slides. So the briefly about the management is, so we need to control the ascites. Once the patient is going for refractory ascites, we need to eliminate the sodium, salt restriction, and eliminate all the triggers like alcohol, B and C virus to be treated to control the hepatitis, check for evidence of hepatocellular carcinoma. If the patient is on beta blockers, whether to stop or give the reduced dose of beta blockers, and you need to subject the patient with large volume paracetamol albumin support. And sometimes if the MAP is very low, that's the most important thing to be calculated. We need to improve the MAP to at least 10 millimeter of mercury over the baseline. So we need to use midodrine, and sometimes for the patient with tips. If nothing works on, patient can be considered for albumin, liver transplant. And along with that, see, these are all the modalities before liver transplant can be considered. And long-term albumin support as per answer trail by Professor PJ's statement we can also think of. And in this presentation, we always to look for other complications. Once a patient develops ascites like tuberculosis, spontaneous battle peritonitis, we need to look for the salt urine sodium potassium excretion, all these things to be taken into account. This is a basic algorithm to manage a patient with refractory ascites. So next interesting area to discuss hepatorenal syndrome. Since there's not much of time to discuss more about this, the brief points I'll be taking into account about hepatorenal syndrome. See, initially there is a one definition by multiple definitions, being the KDO and other classification are there. I mean, International Club Ascites Society classification is there, but now the entire definition has been changed over. The new nomenclature has been there as per the new latest position statement. We mentioned that the HRS1 and HRS2 is not more now. I mean, no more nowadays. That what been taken over that by HRS AKA and HRS non-AKA. So HRS AKA, which means there is absolute increase in creatinine for more than 0.3 millimeter. See, it's nothing but always you should remember that it's a phenotypic renal dysfunction in the background of cirrhosis. So the patient will not be having a structural pathology most of the time, but there are some papers recently been quoted even in ILBS and other string. What I mean, even in case of acute kidney injury, there is evidence, minimal evidence of structural change. This concept is being changing. So we need more papers to validate all these things. And as per the latest guidelines, as per the oldest thing, what's been available with us, so it's mainly based upon HRS 1 and 2, and HRS AKA and HRS non-AKA. We need more papers to validate about this statement. And HRS AKA is nothing but the creatinine, if it is going to be acute kidney, more than 0.3 within 48 hours, and one more entirety, they've been taking urine output if it is going to be less than 0.5 ml per kg body weight for a period of more than 6 hours, and % increase in serum creatinine more than 50% of the value. These things has to be taken into an account to consider HRS AKA. So if you want to calculate the urine output, that's a strong point to be taken into account. Most of the time, the patient will be in ICU care, and you need to catheterize the patient, and with that, we need to calculate all these things. And the second definition is HRS non-AKA, which means acute kidney. In this, the subdivision will be HRS acute kidney disease and HRS chronic kidney disease. So acute kidney means the duration will be around less than 3 months. And the chronic kidney means the duration will be more than 3 months. In this, they're going to calculate the EGFR. EGFR calculation, multiple formulas being available as well known. And the EGFR, if it is going to be less than 60 for a period of 3 months, in this, the EGFR, if it is going to be less than 60 for a period of less than 3 months, which means HRS AKD and HRS CKD. So now the two major entities is HRS AKA and HRS non-AKA. In that, AKD and CKD is the most important thing for a period of 3 months to be taken into account. So what is the basic pathophysiology for this hepatorenal syndrome? That's what I've been discussing in the initial slide. Once a hepatic architecture gets distorted, the splanchnic vasodilatation process, nitric oxide release, as we have discussed, reduction of effective circulating volume, and what's going to happen, the renal vasoconstrictor pathology is going to set in, which will predispose to activation of renin, angiotensin, aldosterone, and sympathetic activation, which will make you to go for reduced renal vasodilation and increased vasoconstrictor processes. The vasoconstricting factors are going to get released, which will predispose to multiple system involvement. So it may go for cardiac dysfunction, sympathetic activity, can go for tachycardia, baroreceptor mechanism activation, and go for ANP, atrionatriuretic peptide release, and sometimes the patient can go for increased renal sodium retention, which will predispose to reduction of solid free water, and then the patient will be having hyponatremia, which will make the patient go for reduction in glomerular filtration rate. So this will make you for the patient go for hepatorenal syndrome to set in. So the basic pathology of renal vasoconstriction and splanchnic vasodilation is the most important thing, along with vasodilatory process to be taken over. And this is a latest picture, from Journal of Hepatology, will be taken into from 2018 position statement what being given in that. So it's mainly because of renal hyperperfusion or because of danger signal by inflammation, which will predispose to microvascular dysfunction, or also because of direct tubular damage. Always the non-AKA, you should remember that other causes like acute tubular necrosis will always mimic this kind of presentation. And when you are going to tackle this ATN and other presentation, always the entire management process will be different. You need to analyze the acute kidney injury. Various markers are there. So many papers are in the urinary gall, NGAL, so many other papers are there. And these things, so we need to look for the basic urine routine, we need to look for the granular cast to see whether the patient is having acute kidney injury because of non-AKA process, other things. Always the ATN, other things also to be ruled out if you are going to think the management. Because if the patient is having acute tubular necrosis, which means if you are going to subject the patient with vasopressor support, it will sometimes it will harm the patient. So all these parameters to be ruled out when you are going to manage a patient with HRS. So the major measure, always we need to eliminate the triggers, general measures if the patients are diuretic. So what is the basic definition? So the basic definition, always you should remember that is cirrhosis with ascites, and there won't be any evidence of shock. There won't be any evidence of structural damage like high proteinuria, microhematuria. And apart from that, if you're going to subject the patient with, I mean, there should not be any improvement in serum creatinine, at least after 2 days of diuretic withdrawal. And after that, once the patient been subjected with albumin support around 1 gram per kg to a maximum dose of around 100 grams per day, even after that, the serum creatinine is going to improve for at least, not going to improve, which means it shows evidence of HRS. And the staging for HRS is nothing but stage 1, 2, 3, and based upon the creatinine values they've been taken into account. These are all theoretical purpose. And apart from that, the most important thing, so what is the main pathophysiology? Always you should remember the newer concept. This is very newer guidelines, 2020 guidelines, what we mentioned in that. Once a portal hypertension or liver failure, if it is going to be there, the bacterial translocation process, PAM mediators, toll-like receptor activation, immune response activation, all these things is going to be there. And multiple phenomena is there, reactive oxygen species and pro-inflammatory cytokine release, which will predispose to splanchnic and pulmonary artery vasodilatation and will lead you to inadequate cardiac output, which will predispose to multi-organ dysfunction like adrenal dysfunction, hepatic N-curve, hepatopulmonary, and the patient can go for renal dysfunction. So the basic bacterial translocation because of PAM, pathogen associated molecular pattern, next to that because of damage associated pattern, and all these things will be predisposing with evidence of cytokine and other activities to set this hepatorenal syndrome pathophysiology along with multi-organ dysfunction. So the treatment is mainly we need to categorize the patient because the most of the treatment guidelines initial as per HRS 1 and 2 are being given in that. So we need to eliminate so suppose if the patient is on diuretic, we need to stop the patient on diuretics, sometimes reduction of beta blockers and potential nephrotoxic to be avoided. And if the patient on suppose if the we need to eliminate all the precipitating factors like severe diarrhea, means we need to stop the lactose, and we need to suppose if the patient is having more of blood loss, means we need to target the blood transfusion. We need to assess by take and rotam assay rather than going for blood. Other things, septic workup. Sometimes what will happen always if the patient is having HRS, you should always remember that the rapid worsening of function in the background of, if the patient is having HRS, always you should remember there is some evidence of septicemia, which is added over in this kind of complication. So always when you're going to treat a patient with HRS, the most important thing, we need to improve, we need to give a complete remission. So we need to give a complete response to therapy. So once you're given the complete response to therapy, the HRS has to improve, and followed by we can subject the patient for early liver transplant and other things. So the most important thing to be taken over, we need to improve, we need to show a significant response once you have been targeted the patient with the various therapies. So there are various therapies. The main thing is mainly for systemic vasoconstrictors like terlipressin is having very potential role, as you are well known, and octreotide and midodrine is still more to be considered, and along with renal vasodilators like other drugs no more in use nowadays. And TIPS placement can be tried along with combination therapy with vasoconstrictors, and TIPS can be tried, and midodrine, octreotide and albumin infusion can be tried, but it doesn't show that rather than terlipressin in other groups, and not showing any significant benefit of improvement. See in this paper, what they've been taken into account, the terlipressin plus albumin, NORAD plus albumin, or octreotide plus midodrine plus albumin, they have been taken into account. So if you're going to use, they are going to see whether the patient is going to show no response or complete response or partial response. So complete response means the creatinine, if it is going to be less than 0.3 milligram per deciliter of the baseline serum creatinine. So how the terlipressin is going to add, as we all know that there are three major pathways. One is by V1A, V2, V1B, and V2. So if its main target is by V1A receptors of vascular smooth muscle, which will to cause vasoconstriction in the systemic circulation as well as the splanchnic circulation. So there's direct intrahepatic vessels thereby reducing intrahepatic resistance to portal flow. So the reduction in portal flow definitely is having, which has a direct beneficial effect in renal function in the background of cirrhosis. So the main important if it's by V1A. So also by V2, V1B, what is going sometimes having aldosterone-like activity, a steroid-like activity. Apart from that, V2 receptors, what sometimes is going to do, some patients, when you're going to subject the patient with terlipressin, the V2 receptors will be actually collecting blood, and this may predispose to hyponatremia and other complications. So that's why we should remember that if the patient in the background of terlipressin, if you're going to subject, some patients can develop hyponatremia. That is mainly because of V2 receptor pathway. That also to be taken into account when you're going to manage to analyze all the spectrum in a proper manner. There are multiple papers to quote that, but how to assess the response to terlipressin is always, if the baseline creatine, if it is going to be more than 5, you should not use. I mean, the potential benefit of terlipressin definitely is not going to be much, and the bilirubin should be, our target should be less than 10, and if the child book status based upon the various parameters, it should be less than 13, and low urinary NGAL values, but value is not much defined. So there are multiple papers to quote, because we need to target the map more than 5 millimeter, and our baseline bilirubin should be less than 10 millimeter, 10 milligrams per deciliter. And these things has to be taken into account if you're going to consider the patient for terlipressin. So the dosage of terlipressin, I'll be coming in upcoming slides. And apart from that, there are other papers to quote for norepinephrine. Norepinephrine also to be equally effective in the management. But what's the problem is norepinephrine, the dose titration is difficult. Multiple papers being tried because cost issue is definitely less when compared to adrenaline. But the cardiac arrhythmias and other complications will be there for noradrenaline and other things. But if you're going to use norad, if you need to give around 0.5 and we need to go up to 3 mg per dose titration can be tried. And midodrine can be combined, but midodrine, the main role, the problem is in HRS type 1, it's really, not much of use in acute kidney disease. And apart from that, in type 2, in the background of AKI, there is some questionable role for midodrine along with albumin support, but still more benefits, more paper aspect, Kevalin et al. What we mentioned that terlipressin plus albumin is far superior to the combination of midodrine, octreotide, and albumin in terms of HRS1 reversal. So the terlipressin plus albumin is first line of choice rather than going for midodrine and octreotide in the management of acute kidney injury in the background of HRS. So this is about the basic outline which has been taken from the recent paper. So stage 1 AKI, stage 2 and stage 3, as I've been discussed in my previous slide, we need to monitor the factors, we need to remove the nephrotoxic dust, and we need to improve the plasma volume, and we need to see whether the patient is showing resolution of symptoms, whether the patient is stable, or whether the patient is being worsening. So based upon that, in stage 1, we need to decide. Stage 2 and 3, diuretics, all the elimination along with albumin support around 1 grams per kg, assess the patient for response, see whether the patient is responding to HRS, whether the patient is responding to albumin and other support, whether the patient is fitting into the criteria of HRS, and then we need to consider with terlipressin and albumin support can be considered, but nothing works on, we need to look for other phenotypes like acute tubular necrosis, ATN, because vasopressor will arm the patient with ATN and other complications, look for granular cause and other things, the separate area for discussion. So, and in this is an outline about the management process where these things will be acting. See, if you're going to use albumin, it is going to act on cardiovascular dysfunction, cardiocirculatory dysfunction, and the reduction of effective intercalating volume. Everything, these are the pathways being inhibited if you're going to use albumin support. And if the patient is having TIPS, means evidence of portal hypertension, liver failure, TIPS is a bridge to therapy and liver transplant. And in the pathophysiology of splanchnic vasodilatation, there is a potential role for vasoconstrictors like terlipressin can be considered. So the recommended dose, we can go start by 0.5 milligrams for terlipressin, and we can even go up to a maximum of 12 milligrams. And the initial bolus followed by 2 milligrams per day. We can titrate the dose, and maximum of 12 milligrams per day. We can go around for a period of around 14 days. We can continue. Norepinephrine, as what I discussed with you, and midodrine we can give by 7.5 or 5 milligrams being tried. Octreotide, if you're going to use 100 mics initially, followed by 50 mics per hour can be considered if you're going to use octreotide. So that shows with all these papers, in this paper, what we mentioned that if you're going to use a vasoconstrictor plus TIPS therapy, the 30-day survival and 90-day survival is going to be significantly better rather than going for a monotherapy. And before concluding about the area of management of refractory ascites, you should always remember midodrine is having a strong potential role in improving the MAP and diuretic responsiveness, and better control of ascites and proper dose titration has to be done. And in PICD, always the scanty data on using cherlipressin and midodrine, but it shows partly effective. But once the patient is going for HRS AKI, the first line of choice is always cherlipressin plus albumin support. The second line could be non-adrenaline plus albumin support, but the benefit effects of midodrine in HRS acute kidney injury is not much of role, and HRS chronic kidney and HRS type 2, nothing but acute kidney and chronic kidney disease, and cherlipressin can be considered. The query in the benefit of midodrine in case of other HRS phenotypes can be considered, but these all need more papers to be validated. And finally, once the patient is going to set in for stage 3 and 4 complications, the renal replacement therapy, like multiple other modalities like slow continuous scuff and slow low efficient dialysis, continue venous dialysis, so much of modalities of renal replacement therapy. But the problem is when to initiate renal replacement therapy, to whom you subject the renal replacement therapy, how to titrate the dose, how to titrate, when to stop the renal replacement therapy, how long to give the renal. Those are all the major still confounding factors to be proven if you're going to subject the patient for RRT. So if nothing works on, consider the patient early and go for liver transplant as early as possible. If the patient is going to present with moderate ascites, you can go for tips at the earlier presentation as per the latest statement, and control the ascites with salt and diuretics as well as salt restriction, along with take care of the refractory ascites and prevent the complication of HRS. Consider the patient for early liver transplant to overcome all these complications in a successful manner. With this, I would like to rest my presentation and thanking you all for patient listening. And I'm happy to take over questions if anything is there to take. Thank you very much.
So you can.
Dr. Arun, that was a very comprehensive and excellent presentation. You have covered almost all papers in this field. So there is nothing much left to be said anymore. But I think the important take-home message is that midodrine is an option for treatment in patients with hepatorenal syndrome, especially when there is a low mean arterial pressure or coexisting hyponatremia. So these are the settings where midodrine has some unique properties over the other molecules. At the same time, the standard of care is terlipressin with albumin, as there is only one direct randomized trial comparing midodrine with octreotide and albumin versus terlipressin with albumin. So this was a small study only. Dr. Arun has already listed it here, but that is a direct randomized controlled trial which tested whether the established practice of albumin plus terlipressin is better, or midodrine could be an efficient alternative. So this study size was not sufficient to give a conclusion in this matter, but as of now the standard practice is terlipressin plus albumin that scores over the midodrine alternative along with the octreotide and albumin. So these are the key take-home messages Dr. Arun's talk has given us. So if there are any questions, you may ask Dr.
I think Arun sir, like if you close the slides, then we all can be seen on the screen actually.
So you want me to close the slides, sir?
Slides, yes, sir.
Yes, sir.
Yes, sir.
Can you able to see me, sir?
We can't see you, sir.
So I can ask a question to Dr. Arun. Whether how often we start midodrine and what is the usual starting dose?
So thank you for your nice question, sir. So the most important thing, see, when's the patient been diagnosed with the evidence of refractory ascites? Because as we all know that if you want to label a patient with refractory ascites, the most important thing, the definition, what they may mention in that, over a period of time, even with a large volume parasitic and maximum diuretic support. like 160 milligram of furosemide and 400 milligrams of spironolactone. And I'm very sure that we are not going to subject this kind of maximum dose to many patients, because if you're going to subject this kind of maximum dose, definitely there is high possibility for the patient to land up in other complications like diuretic intractable complications or diuretic resistant complications can supervene. So to prevent this, once the patient is not showing any response, even with the mild to moderate dose, if the patients, we need to target the MAP, or it should be, suppose if the patient's MAP is around 50 to 60, we need to target a MAP achievement of more than around 65 to 70. So that's the most important thing. So for which we can consider to start with paracentesis along with albumin, midodrine support. So in this background, if you're going to start a midodrine, we can start at least around set up multiple drugs. Many pharmas have been there. Unitro has been taken over in the field. So 2.5, 5 milligrams. But in my experience, I'll be going only approximately around 5 milligrams thrice daily. And sometimes I have been subjected some patients even up to 12.5 milligrams. But usually we'll be giving around 5 milligrams thrice daily to our serial title monitoring based upon the MAP and other parameters, based upon the clinical picture, how the patient is going to respond to that. So slowly we'll be titrating the dose of 2.5 milligrams, escalating, and this thing regimen can be tried over, sir. But some papers have been quoted around 17.5 milligrams also, but we are not going up to that. So our experience in our center around 5 milligrams TDS, or sometimes we'll be going maximum up to 7.5 to 10 milligrams. Most of the time before that, we'll be considering the patient. And the duration can be usually for a month, around 3 months. Some patients will be given for 6 months. And even some patients, papers have reported that even up to 1 year, some papers are there to prove that even up to 1 to 1.5 years as a bridge to therapy can be considered. But as early as transplantation has to be considering this kind of patients.
Okay. Dr. Arun, there are some questions in the chat window. There is a query from Dr. Srikanth, which he wishes to know the comparative efficacy of midodrine in HRS type 1 versus type 2, and whether there are any serious adverse events with midodrine.
The efficacy of HRS type 1 and type 2, now the definition has completely gone, sir. So the HRS type 1 is rather by HRS AKA, and now it's been taken over by type 2 by HRS non-AKA. But in type 1, HRS type 1, what we mentioned, if the creatinine is going to be more than 2.5, and if it is going to be more than 1.5 in type 2. So type 1, the role of midodrine is definitely, it's questionable. It's not much of role, sir. And type 2, if the patient can be subjected for midodrine, but along with telipris and others supposed to be added. But type 2, the very beneficial effects is minimal. But type 1, there is no significant benefit for midodrine, sir.
Okay. Yeah, that's a nice answer, Dr. Arun. There is another question from Dr. Kannan, who is a diabetologist from Chennai. So his question is about diabetes and cirrhotic patients and their predisposition for HRS. That is one question. Another question is, which is more challenging in the management, is type 1 or type 2? So I directed.
Always type 1 is more challenging in the management. It's very obvious because we having acute kidney injury, so it's more challenging. And next to that, if you're going to look in the background of cirrhosis, the diabetes, the hepatic impairment will be around 80 to 90% of the patients will be having a glucose output impairment. Definitely is going to be there, sir. So apart from that, how many percentage of patients in the background of this, insulin resistance, how many percentage of the patients can go for diabetes will be around 30% of the population in the background of cirrhosis can be reported. So usually, if the patient is having coexisting complications like diabetes, hypothyroid, or if the patient is hypertensive, so the possibility of response, the worsening of scenario will be still more high in this kind of background. And diabetes in the background of NAFLD is more difficult to treat. And always we need to eliminate the triggering factors like B, C, alcohol. Alcohol is definitely reasonably easier than all these things to be tackled over.
Okay. So HRS1 has higher mortality and has a much progressive course. Actually, we have dealt with more refractory ascites, which comes in the context of HRS type 2. I mean, this is the erstwhile HRS1 and 2. So this talk actually and the context of midodrine is more in the type 2 HRS.
Sure,
So I think that's the end of questions. If any other questions are there from the floor, we can take it.
Arun sir, video is not coming. I think it's not on.
video is not coming, sir.
Your video is looking off. Off in
Yeah,
the sense, I don't know.
yeah.
I'm not very sure, sir, but I didn't stop my video yet.
Actually, sir, like we are from like a mainstream layman thing. Definitely, patient will come with clinical symptoms. Maybe patient wants to test serum creatinine or other things you can find out in the particular indication. Apart from this, doctor, like many city patients, okay, they are educated and they can get through they have got a lot of they are more blessed to get identified and get treated with the testing. But people who stay in remote areas or were not being gone to diagnostic, what are the clinical symptoms we can see? With this, we can feel, yes, this is might be a RA patient, or this might be a HRS patient, like that. So, is there anything, doctor, by which we can find out that just by have a clinical symptoms or by looks, so we can come to a conclusion that yes, then we can suggest identify the patient, so that prevention is better than cure, because there are many patients who suffer with the indication and they turn back to the doctor maybe in the maybe in the last league, so that the disease progression will be very high. So my question is there any clinical symptoms where we can identify patient of refractory ascites or HRS by just having then we can go for diagnostics and all testings.
Of course, actually, even with the patient in periphery or non-periphery, it doesn't mind going to make any major change. But based upon the etiological factor in whom the patient is going to present, and based upon other multiple parameters to be taken into account, suppose if the patient is having age criteria, some patients will be having female, will be having more worse outcome, and some patients will be having less than 40 kg of weight, and some patients will be having coexisting comorbidities and complications like diabetes, hypertension, obesity, and thyroid and other disorders. All these parameters has to be taken into account. Once a patient being subjected to initial salt restriction and sodium restriction along with diuretic support of the first line of care, in this we need to improve the we need to show the patient with good response to therapy, which means the patient has to have a reduction of weight at least of 0.5 grams per day, 0.5 kg per day has to be improved, along with the urinary spontaneous sodium potassium has to be improved, and all these things has to be taken into account before labeling the patient as refractory ascites. But HRS, even with mild impairment, you should not take as HRS. But usually in the background of chronic kidney disease, the creatinine value will be over around 4 or 5 like that. So usually in our management, the role of midodrine and other things when you're going to set in, so usually it will be in the range of 1.5 to 1.8 or maximum up to 2. So when you're going to subject the patient with this kind of pathology, we can identify whether the patient is having refractory ascites or HRS. So if you want to label the patient as HRS, we need to do a imaging, and we need to look for evidence of structural etiology, structural focus like urinary analysis and proteinuria, other measurement, and imaging should not show any evidence of organ injury, or imaging should not show any evidence of cortical scarring and other things. So all these things has to be taken to label the patient as HRS without evidence of shock. There are multiple definitions for that. And refractory ascites, if the patient is not going to improve even at the maximum dose of diuretic with the salt restriction, if the patient is going to worsen, that shows clear evidence of refractory ascites. But these two entities is the more major complications to be analyzed properly before subjecting the patient for liver transplantation.
Dr. Arun, there are a couple of questions more. One is whether midodrine increases the risk of variceal bleeding. So, any comments?
So there is possibility for, but there are not much of papers for midodrine to increase the risk of variceal bleed. But provided that if the patient is having HVPG measurement, if it is going to be more than 15 to 20 millimeters of mercury, and if the patient is not going to have any much of decompensated, if the patient is not much of evidence of refractory ascites, we are not going to subject the patient with midodrine. But there are some papers being quoted. There is some evidence to history of worsening of because there is some evidence of ischemic events can happen, and there is some evidence of variceal bleed to supervein, but we need still more papers to quote this presentation, sir.
Okay, and there is one last question here, which is indication for renal replacement therapy, dialysis in HRS. But I guess that is, yeah.
Already we have been discussed in a paper. Renal replacement therapy is one final modality once the patient is going for stage 3 and 4 AKI. So once the patient is going for stage 3, which means the complete worsening of renal function, renal shutdown, there is high possibility for you to go for renal replacement. But in this, if you are going to look into ILBS statement, various papers, what they've been quoted about, how is the dose, how long you're going to give, what is the thing, what is the modality of treatment, whether you're going to use cuff or sled, anything, what is the modality of treatment you're going to use. These are all still our data is still more or less if you're going to use a renal replacement therapy to be analyzed in a proper manner.
Yeah, the indications of renal replacement therapy remains the same even in the context of HRS. So if there is a need felt by the nephrologist, we generally go ahead with it. There are no contraindications or special issues. If the dialysis is required, to advise against it. Only the context may be a low pressure, which may make us select a modality which can maintain the patient's mean arterial pressure.
Sure. Any other questions to take over, sir?
I think all the questions have been addressed, Dr. Arun. That was an excellent presentation and an interactive discussion from the floor. So
thank you, Arun, sir, and thank you to team, sir, to join the session. And without you, it will not be possible, sir. Yes, sir.
Actually, it was a very brainstorming session, what I feel, because last week we had a medical presentation when we launched our midodrine, our midohep. And I was going through the way our presenting was like a refresh for my knowledge, actually. And I think this RA and HRS, I think, I got a huge patient population across country. And maybe this medicine can be a blessing for those patients to come back to normalcy and they can have a better quality of life.
But we want, so the one thing I want to share with you also before switching over, because there are so many farmers have been coming with midodrine. Initially, the cost was very high, but I'm expecting the cost has to be slightly low for which we can subject the patient. We can go for multiple trials, and it's very easy for even the patients to buy over that. So you need to consider, refining the cost and other issues to be considered.
Definitely, sir. Petro being, I think, basic manufacturer, the patient friendly, we'll be at our best to keep that thing in place, and maximum patients will get benefit with our midohep, actually. And yes, Arun sir, anything else?
No, nothing more to add.
So really, it was a great evening, a great show, and really, I want to salute you, sir, for the excellent moderatorship, and Arun sir, the way he presented, it was a fantastic presentation across. I really thank you, Dr. R.S. Arun sir, for being a moderator for the evening and taking the webinar to the next level. And Dr. N. Arun sir, really it's a lot of in-depth knowledge. So we meet several times. First time I'm seeing you in, although I see a lot of your videos with their different subjects, but this is something great. And really thank you very, very much for being with us in this evening. And apart from this, sir, behind the scene, we have a marketing team. I'd like to thank Mr. Nehru sir for being all the support. Our marketing team, Ms. Sweta, Aditi, Lakshmi, Akshay, and Kanan, and our IT team in Hyderabad, Mr. Bharat. We all thank you all for being there for this program. And I wish we have a lot of things in roll, sir. Coming weeks will come with more exciting, more better topic, more good topics, and new formulations, new experiences. And definitely, I would like to get your blessings for forthcoming events and programs also, and look forward to associating coming days. Thank you very much for being here, sir. Have a great day.
Thank you, Dr. Arun sir, and thank you all the participants, and thank you, Team Metro.
Happy weekend. Despite weekend, you are all here. Really great. Thank you very much, sir. And
thank you, sir. Thank you, sir. Thank you all.
Good night, sir. Good night, sir.
Good night.